So it's a real pleasure to be here with Dr. Stephen Porges. It's a delight to have you with us, Stephen. My name is Dr. Alan Hakim. I'm a rheumatologist based in London. I'm the Director of Education for the Ehlers-Danlos Society. Stephen, would you like to introduce yourself?
Yes, I would. Well, thank you, Alan, and thank you for inviting me to be on this dialogue with you. I'm a professor of psychiatry at the University of North Carolina and a distinguished university scientist at Indiana University, where I founded the Traumatic Stress Research Consortium.
Thank you very much, Stephen. And so today we're going to be having a conversation around Ehlers-Danlos syndromes, hypermobility spectrum disorders, and the relationship between anxiety and hypermobility, and sort of thinking about mechanisms and therapies and how we can be informed and help our community. So I'd really like to start with getting your thoughts on why you think anxiety might be so prominent in hypermobility.
Well, this is a very, let me first say that about 10 years ago, I never heard of hypermobility syndromes or EDS, and I received an email from a mutual colleague, Tony Balbena, and Tony said, I have seen your body perception questionnaire. I'm very interested in using it with EDS. And I said, really, what is EDS and why? He said they suffer from much anxiety, and we'd like to get at least a subjective measure of autonomic reactivity. So that was the door that was open, and I really appreciate that. And then the second door was opened by a colleague, Katja Kovacic at the Wisconsin School of Medicine. She's a pediatric gastrologist, and she basically contacted me and said, we're measuring autonomics. Can you help me or guide me into autonomic measurements? And I asked this big question. I said, who are your patients? And she said, there are adolescents who are going to the GI clinic for pain. I said, let's learn about them and let's learn about their basal physiology and see if we can learn something about that, because she was doing basically electrical stimulation of basically vagal afferents in the ear to reduce gastric pain. And to her surprise and to my bewilderment, over half her population had Beighton scores over 4, in a sense, and many of them were undiagnosed. And what we discovered, and I view this as a discovery, was that the autonomic profiles, even in their baseline conditions, were uniquely different. So literally, you could start making a prediction based on autonomic state and autonomic regulation of whether or not they were EDS with a high degree of predictability. But the question, and that information converged in my mind and said, this is obvious. The autonomic nervous system is regulated in a different way in those with hypermobility syndromes, organized in a different way that their bodies are now prepared to be defensive. And what we're doing is we're misunderstanding the word anxiety. We're treating it as if it is a psychiatric problem, a psychiatric disorder. And what we really should be doing is interpreting it as our body giving us signals that the body's nervous system is under a state of threat. Sorry for the long-winded.
No, that's absolutely fascinating, because those who will have been able to follow the sort of story, if you like, that unfolds in front of us, can really go back to the late 1980s to some of the first seminal publication from Antonio Balbina in The Lancet. And then you can come forward over the decade where you start to see more of the description of the association between anxiety and hypermobility, but also fascinatingly panic disorder as one of the types of disorder. And then comes in our observations in the same decade of the association with autonomic dysfunction, whether it's Thoreau's work on POTS. And you start to see these links. And I was fascinated by the fact that you were very early in those conversations, if outside of EDS, generating the polyvagal theory and this whole theory around the association between brain and body, and, if you like, the reactivity of the autonomic nervous system. So how does that fit sort of historically with what you see unfold?
Well, we have to go back before polyvagal theory. It didn't all start there. And I wrote a chapter on literally the history of neurocardiology. So the history really is in understanding that the nervous system has always regulated our autonomic nervous system, meaning the brain plays a major role, and the autonomic nervous system is sending a lot of information or visceral organs up to our brain. So the notion of a integrated single nervous system is an old idea. And in fact, Walter Hess in 1949 received a Nobel Prize for talking about brain regulation of visceral organs. But it was a complicated construct in the world or field of, let's say, applied medicine or practical medicine, because you had to think about feedback loops. And medicine evolved to look at organs, not the neural regulation of the organs. So here we have the problem in terms of medicine doing diagnosis on end organs without any tools to measure the dynamic neural influence of those end organs. And what polyvagal theory brings to the table is the question, wouldn't the neural regulation of the end organ be, let's say, disrupted? Wouldn't that precede the damage to the end organ? So if you're looking at the ontogeny of disease, wouldn't you want to see when the nervous system is putting the organ in a state of, let's say, defense, and then when the autonomic nervous system can no longer optimize the regulation of the end organ? And this is in that sequence. Polyvagal theory identified that sequence. It basically said we have our evolutionary heritage embedded in how we react to the world. When we're safe, we use our neural circuits, which are to become accessible, calm, homeostatic. And when we are placed with a threat, we try to mobilize, fight or flee, and that turns off the neural regulation of our end organs. And we call this in our world stress or chronic stress, and anxiety is one of those features. But there's a third stage in polyvagal theory, and that is there's a shutting down where the nervous system is no longer a major player. It's a shutting down response that is an ancient, let's say, reptiles used it very effectively because they didn't need much oxygen. Mammals, we need a lot of oxygen. So this immobilization or shutting down is really the worst, not good for us. So we can see that if our bodies are under stress or no longer in a state of homeostasis, anxiety is that interpretation of that physiological state.
It's fascinating because I think in taking it from the clinic and listening to my patients, and we listen to the community, many of our community will tell us that they don't necessarily feel that they have an anxiety disorder. Mm-hmm. What if they do have more of a primary anxiety disorder? These other sets of symptoms that have a massive impact on their quality of life can be separated from that. They know that they're different. And yet, first and foremost, they're usually primarily considered to have an anxiety disorder.
Yeah, I think this has to do with, let's use the term, the silo effect of medicine, that where anxiety is really viewed as something in the head and not a product of the body. And it has to do with treatment models historically, which moved to pharmaceutical models. And they felt that the mental activity, the manifestation of anxiety, was a brain phenomenon and had little to do with the body. People from my subdisciplines who are interested in body relationships, the origin of emotions and motivation, and never saw it that way. So in a sense, the behavioral neuroscientist had a different perspective, and then when confronted in the world of psychiatry, was shocked that these physiological responses were now being interpreted as if they were mental experiences. So it has a lot to do with the filters that we put on the same exposed or same experience.
Absolutely. So I was fascinated by this short form questionnaire that you had developed, the body perception questionnaire, because it seems to me that this is a mechanism by which we might be able to articulate how we're feeling, as opposed to just simply using the word anxious.
Yeah, I think Tony had that insight and brought me to the table on that. And we are actually working on finishing up a manuscript where we actually measured physiology with simple challenges to see if there's a correlate between the subjective statement of autonomic reactivity and the physiology, and there is. It's just not published yet. And we're finding out that the measurements from this scale, the body perception questionnaire, are telling us a lot about predictability of reactivity to threats. But what's most interesting in our current research, and this actually overlaps with the world of EDS, is that trauma history seems to get mapped into a retuning of the autonomic nervous system. And that is what's related to outcome, not the trauma history. It's the translation of the traumatic experience into a retuned autonomic nervous system. I bring that up in terms of the EDS platform, because as I read Stephen Dane's book, I felt I got a quick download of where the literature was. He honored me by asking me to write a short preface with other people. But it was very interesting to me that there were two important points that basically came through the chapters. One was that often the manifestation of this hypermobility syndrome, even though it's a collagen disorder, had a trauma trigger. And second was the covariation with dysautonomia.
Right.
And so you now have a trigger, you have a dysautonomia, and then you have a full-blown disease. And this triggered in my mind this whole possibility that many of these characteristics of autonomic dysautonomia, autonomic features, could be decoupled from the underlying disorder. Because if we look at them adaptively, the body, the nervous system, is interpreting the cues of the trauma and the disease and putting that into a reaction of chronic threat. In a sense, it's exhibiting threat reactions. So what we call dysautonomia starts off with a threat reaction. And then the consequence of that threat reaction is a degrading of the neural feedback with the end organs. So now we have dysfunction of the end organs, and we call it dysautonomia. But even the tests, so if you tilt someone and challenge their baroreceptors, the blood pressure receptors, you're testing whether that neural feedback circuit is efficiently doing what it evolved to do. And you're seeing that the neural feedback loops are basically compromised.
Absolutely. And I'm really keen to pick up on this point, because I can see from the literature that we've worked hard to look for mechanisms that may be pertinent to explaining autonomic dysfunction, particularly cardiovascular or bowel autonomic dysfunction in EDS and hypermobility spectrum disorders. And yet actually you see these phenomena across the breadth of many conditions, which for us has also been a dilemma in terms of its position as part of diagnostic criteria. And you've mentioned post-traumatic stress disorders, which are highly variable and very, very common amongst our patients, but amongst many other patient groups. And autism, presumably, chronic pain disorders.
You're touching into the world that I spend a lot of time in. But about 20 years ago, I asked the same question you're asking, but within the area of psychiatric diagnosis. I said, all these diagnoses have an autonomic component. And that's when I was trying to write grants to fund this kind of research. And I realized because autonomic components didn't have specificity, and this is your same question, the funding agencies, especially the advocates for those funding units, were disinterested. They wanted a neurobiological signature of the disorder. And I think that was let's say, a misconceived perspective. I don't think it's the appropriate one. I think if we understand the nervous system, we see that there are some basic structures that appear to be dysfunctional and common to many types of disorders. And then higher level brain structures, in a sense, retune or create greater specificity of the specific disorders. We may be able to treat, and this is a term I really don't like, but treat the symptoms when the symptoms are really that the body had moved into a state of threat reactions, and that might be treatable. And it may be that we can do that and reduce the complexity of the expressed symptomatology. So if you have a collagen disorder like EDS, but really all the symptoms are coming out. The painful symptoms are coming out through autonomic dysfunction, or many of them, and the feedback of that. If we could, in a sense, dampen that, what would be the quality of life for people? It's the same question with autism that you brought up. Autistic individuals, their autonomic states are also in a state of threatened defense. And if you retune that, and that's where a lot of my work has been going, that they start having better, let's say, even spontaneous social engagement, better gut function, better, in a sense, regulating better within society. In fact, we are doing a clinical trial with EDS individuals who have gut problems. This is with my colleague Katja Kovacic and my colleague at Indiana, Jacek Kolaks. And what we're basically doing is testing the model that if you send signals to the brainstem through acoustic signals of calming, do the symptoms disappear? And this is functionally an acoustic vagal nerve stimulator. We have to conceptualize that. We have to think in terms of, well, we have acoustic vagal nerve stimulators throughout our lives. Think about what the mother is doing with the baby as she uses her prosodic voice. I just extracted those principles and amplified the prosodic intonations. And so we're doing that intervention. And it's interesting. We've done little pilots. We're doing a pilot with Parkinson's now. And one of the therapists actually worked with this intervention with an individual with Parkinson's. So on a single subject, there was a reversal in facial expressivity and vocalizations, which is really a surprise. And it's most likely the same types of features. Parkinson's is a real disease, but the symptoms that we link together may not be part of that real disease, but a response to it. And I optimistically think that EDS is the same thing.
So right back in 2003-04, myself and Professor Rodney Graham fashioned a model which we published in a very small little paper that proposed, it was a hypothesis that proposed some form of link between hypermobility and instability, chronic widespread pain and deconditioning, anxiety disorders and autonomic dysfunction, and had this idea that there were then, as a consequence of this, multiple interventions that we might apply to try and damp down all the symptoms. What fascinates me is if you jump forward to the early 2010s, colleagues like Jessica Eccles are starting to explore and identify this relationship with autonomic dysfunction. And then you come forward again to the late 2010s, and people like Marco Castori are publishing complex presentations in both HSD and EDS, where the primary concern is autonomic dysfunction. So I think within the world of hypermobility, anxiety, and autonomic dysfunction is the key. And I'm really keen in our last few minutes to get a sense from you, probably I suppose from a medicine's point of view, how different medicines might actually really be playing a really important role here. We know about beta blockers. I think they're quite commonly discussed in this context, but there are many others, aren't there?
Well, I would basically, I'm going to give a very cautious reaction or response to that question. And that is, we tend to focus on pharmaceutical manipulation. That leads us to level shifts in autonomic function. And what I really want to emphasize is that autonomic regulation is dynamic and neurally regulated, or there's a major neural component. And within medicine, even within the diagnosis, that neural component is minimized. So because the focus is on the end organ, from this polyvagal perspective, the emphasis is on neural regulation, which really means brain regulation of the end organ through neural feedback loops, optimizing the feedback loops to optimize homeostatic function of those organs. And this, I call this neural exercises. So neural exercises are challenging this system. It could be posture shifts, and in a sense, we're rhythmic posture shifts. It can be, it's like any challenge, or even listening. If listening involves the engagement of the facial cranial nerves that regulate the muscle of facial of the face, including the middle ear muscles, it will have an impact on the vagal regulation of the heart. I want to tell you what we know. So we know that the vagal regulation of the heart dynamically is adjusting the pacemaker. And the efficiency of that vagal pathway, I created a metric that measures that efficiency, which tells you how much heart rate changes do you get with slight changes in that vagal input. I call it vagal efficiency. Mm-hmm. And interestingly, vagal efficiency is lower in preterm babies. You can see it develop. Doses of alcohol, it's about linearly affected. EDS is noticeably different. EDS kids with functional abdominal disorders are noticeably lower in vagal efficiency than their peers who are not EDS in the same clinic. So the other part is, even in a college sample of people who have maltreatment histories but not full-blown PTSD, it's lower. So now we start seeing that the intrusion of trauma dysregulates through reducing vagal efficiency, which is a surrogate for saying the neural feedback loops regulating our autonomic state are being deficient or defective. Now, what I really want to know is, can I optimize vagal efficiency? Can I intervene? I think within EDS, it's going to prove to be extremely powerful, and it will change the treatment of anxiety from something in your head to a real objective measure of that neural feedback loop. And I think there's been a victimization of many individuals who get diagnoses of EDS in terms of not the medical profession not understanding the source of the chronic pain and not understanding what the disorder or the anxiety, because they're looking solely at that end organ and not at the feedback regulating it. And that end organ is producing tremendous amount of information that's going up the sensory pathway of the vagus to the brain, affecting our mood state, who we are, whether we can engage others, whether we're safe.
Thank you for that. And I deliberately asked the question about medicines because my experience of them is that they often just do not work very well for our patients. Often they feel so much more ill. And, there are agents like SSRIs, NRIs, pregabalin, benzodiazepines. They've all not, as far as I can tell, not got a great place here. In terms of just finishing, in terms of self-management, and I suppose this concept of brain regulation, Are we talking about things like trying to remain active, looking at good sleep control, breathing, relaxation techniques, all these different sort of types of techniques that are, I suppose, part of the mind-body philosophy?
We can shift out of using words like mind body, and we can talk about, can we employ neural exercises? Let's elevate it. Yeah. And so breathing is a beautiful neural exercise because it turns inhalation functionally dampens vagal efferent activity, and exhalation enhances it. So we are, through our breathing, we are, in a sense, doing a neural exercise. If we do abdominal breathing, we are pushing that system more. Many of the attributes of yoga are neural exercises. Play is a neural exercise because it's movement, inhibition of movement, and facial interaction. So there are a lot of things we can do that gets our nervous system more regulated, more exercised. I wanted to bring up something else, and that is basically to enhance neural regulation or homeostatic function, we need neurotransmitters. Mm-hmm. And neurotransmitters are, in a sense, partially dependent upon the building blocks of the foods and the substances we ingest. And the cholinergic system, acetylcholine, is a primary one for vagal function, but that system is also anti-inflammatory. Mm-hmm. And so now in the world of rheumatism, you understand where I'm going. So the building blocks for acetylcholine, such as I take personally, I will just share with that, lecithin, and lecithin has phosphatidylcholine, which is a building block for acetylcholine. What you don't use, you just metabolize. So in a sense, the idea is we need to eat the right building blocks to support the neurotransmitters in our system to help these neural exercises work.
I think this has been an absolutely wonderful conversation. And what I would say is that I think that across the course of the conference that we're going to have over the couple of days, we're going to be exploring a number of these different elements that you've just been describing there towards the end of what I think has been a fascinating kind of discourse through from the relationship between hypermobility and anxiety to autonomic dysfunction to self-management through neural training of autonomic dysfunction. Thank you so much, Stephen. Any final words from you?
No, what I say is thank you for welcoming me. And actually, I have to thank Tony for bringing me into this world, because I've learned so much. And as you and many of us, what our goal is to reduce the burden of suffering. And I think through understanding the mechanisms that we hopefully will start alleviating that burden.
And you will be with us for our Q&A, hopefully a little bit later at the end of our session.
I will. Thank you.
Thank you so much for your time today. Pleasure.